As the traditions of the annual general meetings are, we will need a proposer and a seconder so that we can run the affairs of the day. Do we have any member proposing? Just show of hands. All right. Yeah, please. Oh, Dr. Good. Dr. Wafula Nalwa proposing. Seconder. Okay. Ann Maina seconding. So our meeting is officially on. And without much ado, it's my pleasure and honor again to bring the national chairman of the Rural and Urban Private Hospital Association, Dr. Brian Lishenga. Put your hands together for Dr.
Thank you, Vice Chairman. God is good. And all the time, God is good, and that is his nature. We add what? Wow. Isn't it? Wale ambao don't go to church or to any religious place, you got lost, eh? My name is Dr. Brian Lishenga. These days I have problems walking around the streets because I'm on TV too much. But it is my great pleasure to welcome all of you for the 5th Rupha Convention. I have a very simple task right now, and I'm going to go straight into it. My task, if you look at your program, is to invite the guests for this morning. We are expecting the Director General for Health, Dr. Amoth, to be representing the Principal Secretary. I think he's going to arrive any time now. In the meantime, Dr. Luenyu, you know now you are in government, you'll tell me if I'm doing protocol the right way. In the meantime, we are very honored today to have other guests, other chief guests. We have Dr. Timothy Oluenyi, who is the chairperson of the Social Health Authority. We have Madam Jacinta Mutegi, who is a board director with the Social Health Authority. And Jacinta, you remind me that you are there on behalf of providers, isn't it? So we have quite a bit. We have Dr. Wasuna from Farm Access. We have, I am forgetting your name. Just let me ask the name. All right, got that. Dr. Shafiq from Universal, who's speaking about procurement. So these are among some of our chief guests. We have Lillian Gashoki, am I right? From Dream Credit as well. Who am I forgetting? So quite a number of our chief guests have already arrived. So let me start with Dr. Timothy Oluenyi, who tells me that he has board meetings today. So I'll keep this very brief. I have known Dr. Timothy Oluenyi personally for the last 16 years. Daktari, it's been time, eh? Now, I have known Dr. Oluenyi for the last 16 years. And I was just telling my friends when we were, having a breakout session that Dr. Oluenyi was actually my first employer, private sector employer. We go a long, long way back because once I finished my internship at Moi Teaching and Referral Hospital, and these guys were laughing at me 1 minute ago, I was posted post-internship immediately as medical superintendent, Londiani District Hospital. And I think Dr. Asuna asked me, you mean you were posted as a med sup immediately after internship? I said, yeah. That is the reality of the health system in Kenya. And I've just been telling them, that my experience was so shocking that I could only last there for 6 months. And I quickly started looking for a job elsewhere because the first patient I saw was an epileptic who had had an epileptic fit while they were by the fireplace. Walikuwa wanaota moto. They were just how I ended up knowing Dr. Olwenyi. He is an exceptional entrepreneur and an exceptional leader. I have served under him, and I can tell you from my own private experience that unless there are some other evil spirits that catch people when they go to government, I am fairly confident. I am fairly confident that with Dr. Timothy Olwenyi as the chairman of the Social Health Authority, we as healthcare providers in Kenya are in safe hands. I am fairly confident. And especially as private healthcare providers, because he has lived through our experiences, he knows our struggles, he knows our pains, he can actually speak for us. So Dr. we have a lot of hope in you. The topic that we invited you to speak on is on the transition from NHIF to SHA. People have a lot of issues. I hear they say, is it SHA or is it she? And then some people now say it is she-SHA. Daktari will help us to understand. But the topic we gave Daktari is, why did we need to transition from NHIF to SHA? Was the change really necessary? So, and I don't know anyone more perfect than you to speak about this. And I know all the providers gathered here and our stakeholders are excited to know what was the thinking, what is the rationale that led us to this point where we are moving from NHIF to SHA. So without any further ado, it is my pleasure to welcome the chairman of the Social Health Authority, Dr. Timothy Olwenyi.
Good morning, everyone. As you've heard, my name is Dr. Timothy Olwenyi. I'm the chairperson of the Social Health Authority. You know, Brian is a politician, so and I have to be careful because when he gets to Senate, I might have to appear before him also, so I have to be careful what I say today. Well, I must say it's a great pleasure for me to be here. First of all, I'd like to acknowledge the presence of all the guests who have come in today, all the members of Rupha, and allow me to be selfish. I also have a lot of people who are members of the Social Health Authority. Maybe you can stand up and just we acknowledge your presence, Director Jacinta, and the rest of the team who are also here from Social Health Authority. Okay. Now, I was given a topic today which I feel is actually very appropriate because it is a topical issue right now. And I don't usually give speeches, read from speeches, but today I had to take a few notes because of the level of importance. And I think it's important because the team in this room is going to be very instrumental in being able to spread the gospel, so to speak, about why this transition was necessary. Because I've had a lot of comments about people thinking it's purely a change of name. And that is not the case. So firstly, I'd like to emphasize that Section 43(1) of our Constitution actually states that every person has got the right to the highest attainable standard of health care. So it is a constitutional right. And in addition to that, nobody should be denied emergency treatment. And the government has got a constitutional imperative to ensure that they put in place legislative policy and other measures to ensure, including setting standards to achieve the progressive realization of that right. Now, there have been previous attempts in terms of trying to achieve universal health coverage. And there was then a SHIF attempt, it was called the National Social Health Insurance Fund, which was done 2 administrations ago. And that didn't succeed for various reasons, I'm not going to go into the details at the moment, but that didn't work out. Then there was also a UHC attempt in the previous administration where we were thinking about input financing and seeing how if there were pilot counties, and we were going to see if that could be able to achieve universal health coverage. Again, for various reasons, that didn't work out. So the key thing here is in this attempt that we are making this time around, there had to be a little more thought and learning from lessons from the previous attempts in terms of ensuring that this time we get to where we intend to go. Now, an ideal healthcare system has got to be comprehensive. And that's in terms of scope, in terms of the range of services that they deliver. It also has to be responsive, and responsiveness refers to the expectations of those who are accessing the healthcare services that they need. It has to be reliable. It also has to be progressive, and progressivity refers to the model of financing, and we can go into the details of that later. It has to be sustainable, and especially from COVID experience, we also have to learn that it has to be, a healthcare system has to be resilient. Resilient because in the absence of us being able to prevent, prepare for, detect, adapt to, and respond, and then also recover from health threats, then it means our healthcare system is at the risk of collapse. And we saw that globally. Much as COVID came from quarters which came at a time we didn't really anticipate it, but it actually showed how our healthcare systems can collapse in the light of a threat. And especially in Kenya, you could see in terms of the financing arm, at that point in time, the population were left to their own devices in terms of medical bills. Because you know, all insurance companies were very quick to quote force majeure and say this is a pandemic and we don't cover it. So even those who thought they had medical insurance, whether it's NHIF, whether it is private, at that point were left in a situation where they had to fend for themselves in terms of paying for medical bills. Now, the Kenyan healthcare system has had various challenges, and these I don't need to overemphasize because we have all lived through them. Firstly, there was that increasing emphasis that we've had on curative care as opposed to preventive and promotive. And the growing burden of NCDs, non-communicable diseases. And that, of course, puts strain on the resources we have within our healthcare system. So there was need for us to rethink. The healthcare, and this also, the aspect of healthcare insurance penetration. It is, depending on who you talk to, it is 10 to 20%. That is still extremely low, which means that at the end of the day, there's the predominance of the issue of out-of-pocket expenditure. And out-of-pocket expenditure is one of the most inequitable ways to be able to pay for healthcare. And we've seen the catastrophic effects in terms of people trying to pay for healthcare expenses out of pocket. Then the vehicle that we had for healthcare financing, which is NHIF, had got some design flaws. And I'm going to say design flaws, and we can't really blame NHIF for that design flaw, because at the time the idea of NHIF came into being, the needs were different. At that time, we looked for a way of being able to, it was designed to be able to take care of those in formal employment, to be able to access healthcare services. All right? So that was the original design. And that same vehicle, we have kept it for 60 years without changing it too much. And so, for example, there's over-reliance on statutory payroll contributions. So you find that the most people who are contributing to NHIF were people in formal employment, and because it was statutory, they didn't have a choice about it. Next, there's this aspect of flat rate contribution from those in informal employment. This is one of the biggest problems we have, because it doesn't matter whether somebody in informal employment makes 1 million shillings a month. They were going to pay 500 shillings a month as a contribution. So literally the people in the informal sector were not carrying their weight. And that needed to change, because at the end of the day, especially if we're going to talk about a social health insurance system, then everybody needs to carry their weight. And it has to be one of those where everybody contributes, otherwise the model doesn't work. So enrollment was low, contributions were erratic, because at the end of the day, because of the adverse selection, a lot of people in the private sector, in the informal sector, when they realize they're going to need to access the services, is the only time they will contribute. The other times, they will sit and wait. And there was no way of enforcing it. Legally, by the way, NHIF contributions were already mandatory. However, in terms of enforcement, there was no way to enforce them. Then there were aspects to do with operational efficiency. Operational efficiency at the fund, the administrative costs were high. In the last few years, there have been attempts to bring them down, but again, they were still inordinately high. So the objective should be that most of the funds that are collected should go towards actually paying for benefits for members, as opposed to administrative costs or investments or anything else. Then there were concerns about poor responsiveness to customers and stakeholders. And you, as one of the major stakeholders, I'm sure you've had concerns. I used to be on the other side of the fence, and I know what difficulties there were. So those things need to change. The claims processes, because especially of the manual nature, they were inefficient. Sometimes the turnaround times were long, and of course there was a perennial complaint about delays in payment. Then healthcare provider compensation mechanisms, again, sometimes lead to misalignment in terms of objectives. And I'll give an example. If you are going to have a fee-for-service model, for example, then you see it becomes in the best interest of provider to, for lack of a better term, I'll say, is to create work. They keep saying, if you want to know whether you need surgery, ask a surgeon. Because that's the business that you are in. At the end of the day, of course, the inclination will be to recommend it. So those things needed to be realigned. Then there were so many schemes that were run within NHIF. And these schemes, there was a lot of overlap. For example, you have somebody who is covered under his household, he's a formal sector contributor. He has got his child, again, covered under EduAfia. His wife might be covered under Linda Mama. But more importantly, for a social health insurance system, you cannot have the impression created that some people are more equal than others. And once you had especially these enhanced schemes, the impression was that some people were more important. So there was confusion because the ordinary people don't know that when somebody is taken for treatment to India, it is because his employer has contributed a little extra. So the perception is NHIF is being discriminatory. How come some people go to India? And then when I have a problem, I come and ask, I'm told, no, you are not allowed to go to India because you are in this scheme. So the intention was to try and standardize the schemes. There has been a lot of talk, and especially in the recent past, about corruption, fraud, and resource wastage or leakage. And that is one of the biggest things that as a social health authority we have to deal with. First of all, there's not too much goodwill carrying forward. So at the end of the day, we are going to have to really crack the whip and ensure that all this resource wastage, through whatever means, is curbed. One of the problems that was there also is that NHIF was seen as the judge and the jury when it comes to a lot of things in terms of healthcare financing. NHIF used to do the accreditation in the past. You do the accreditation, you do the empanelment, you do the contracting, you decide what benefits package you're going to pay. They decide how much to pay you, when to pay you, when there's a dispute, they decide. So there was need to segregate and bundle all these functions and make the process more transparent, more fair. So, and then there's the aspect of leadership. And that's one of the things that, again, I will highlight about the Social Health Authority that has changed. Other things in our healthcare system is there still persists an issue of regional and socioeconomic disparity in terms of resource distribution. So for example, in the area of infrastructure, and I use the term infrastructure in its broadest sense, in the terms of physical, financial, human resource infrastructure, and so on. So especially, for example, if you talk about the distribution of resources, physical infrastructure, in terms of how the healthcare workers are distributed countrywide, there's always a predominance of having people more in urban areas and a lot of the time concentrated within Nairobi. So there's need for us to be able to decentralize this, and the question was, how do we do it? After the enactment of the Health Act in 2017, there was an emergency fund that was supposed to be operationalized. And one of the things that we always advocated as a private health sector especially was that, okay, it's a right, and we are not allowed to deny anybody healthcare, especially in emergency circumstances. But who pays for it? The addressee of those rights claims is the government. And the question was, the government never operationalized this fund to provide those services. So at the end of the day, it became that in an emergency, whoever sees that person is the one who incurs that cost, right? And that could not be sustainable. So you find a lot of people, if for example, you had an ambulance at your facility and there was an accident next door, the tendency would not be that you're going to collect all those people and bring them to your facility, because it becomes at your expense. And so that needed to be sorted out. Then, of course, there's the debate about the rising cost of healthcare. In my view, universal health coverage can't be achieved if the costs keep escalating. There has to be a way in which we have a wider discussion amongst all health sector players to be able to bring down the cost of healthcare. So there's the increased cost of expenditure on curative services, which I've already mentioned, the issue of non-communicable diseases now taking a larger chunk out of the healthcare costs, but in addition to that, healthcare commodities. And healthcare commodities, interestingly, it was estimated, I think, that about 20% of all the costs are because of pharmaceuticals and consumables. And 70% of those come from out of the country. So there was need for us to be able to look for a way of being able to rationalize that supply chain and bring down those costs. Then our referral system. Our referral system, again, is one that I'll use the term disorganized. Disorganized because you can wake up with a headache, and I keep joking with my patients, why don't patients ever diagnose simple things? When a patient has a headache, he says he has a brain tumor. I'm like, why don't you just be a stress headache or something that we can manage? So based on that, they will go and see a neurosurgeon the next morning. Literally, this neurosurgeon is supposed to be seeing people who are referred from other healthcare providers in terms of being ascended into healthcare, but this person is sitting there taking that space for somebody else who needed more attention. So the healthcare system, referral system, needed to be streamlined. And so that needed to be ordered. And then again, the lastly, and I'm just listing out the problems, not in any particular order, but we have got a lot of programs which are funded by donors in this country. They're referred to as vertical programs. For example, the HIV programs, TB, and so on. And we had got funding that is coming in, but there's no real plan to transition this to domestic financing. So for example, if a donor pulled out, what happens next? We start scrambling and looking for resources to be able to take care of this, this crucial part of healthcare. So that needed to be done. Now, allow me to digress a little bit and talk about healthcare policy development, because we are discussing how did we get where we are today. And I always want to emphasize that it's not that people woke up one day and said, let's change NHIF to Social Health Authority, and that's it. There's a lot of thought that went into this. Now, there's a model I like talking about. It's called Kingdom's Multiple Streams Framework. And what happens is this. We have got problems which are clear, which have delineated in the healthcare system. All right? For us to be able to look for that policy window when we can implement change, policy entrepreneurs have to be proactive. They have to create policy ex ante, before the fact. In other words, you have to have thought about the problems and come up with solutions and wait for the right opportunity for us to be able to implement. And that opportunity, those three streams, you've got the political stream, the problem stream, and then you've got the policy stream. So the problems are there, the policy is ready, but the political stream has to be ready. And that only comes on occasion. And a good example is, it can be predictable. Like for us in our case now, it's because there was an election. An election where you have got an incumbent who's not running. So you know that is an opportunity for you to redirect healthcare policy. So policy entrepreneurs like myself, and the truth is all of you are policy entrepreneurs, and or should be. At the end of the day, we take different routes. Some people go into deep into politics. That's why I respect Brian and the approach that he takes, because that's not a route that is easy for everyone. But then again, for those of us who are policy entrepreneurs, we have talked about all these things for the longest time. For the last 15 years, I've been talking about these changes. And what happens is every time you go and sit before parliamentary committees, you do public participation, you do ABC, but at the end of the day, the bill, when it comes out, looks exactly like it was going in, all right? So there's a lecturer at Strathmore Business School. He came to give a talk from Harvard. And we gave him the discussion once, and the usual thing of Kenyans saying politics is a dirty game, our leaders are doing ABC, and so on and so forth. And he listened to us, and then in the not so politically correct words, you can imagine the exact wording he used. He said, can you Kenyans just quit complaining all the time? You've got so many smart people amongst you. And what do? You step back and let the idiots run the show. He said, I can tell you one secret. You cannot change anything if you're not in office. Do what you need to do to get into office, then do all those good things you're talking about. That's why I've got a lot of respect for Brian, because he took a dive, which is not usual for doctors, by the way, to go into those political circles. My approach was slightly different. When the politicians were doing their campaign period and they asked for feedback from stakeholders like us, the association I represented at that time did not even think we should go and talk to them. All right? And I'm saying, for example, for the current administration, a lot of the time people didn't think they even had a shot in terms of being in office. And my position was, one of these two teams is going to be in office. Our issues need to be on the table. So, if the other team also calls us, we'll go. So I went literally against the wishes of my association at that time, and I said, I'm going to say my bit, isn't it? And that is how I went and talked for 45 minutes on all the healthcare policy issues that I thought needed to change. All right? That is why I'm here today. It's not because I had any political influence, all right? You know, there's some shareholders register that goes around. I'm not on that one. Okay? But that's why I'm saying things don't just happen, they are caused to happen. So that is my message, especially for those of us in the health sector at the moment. You have got to position yourself anytime there's change. You remember, for example, when we talked about the Health Services Commission many years ago, when the constitution was being written, the doctors were busy treating patients. And when the legislation came out, there was no Health Services Commission. And we've been trying to fight that for the last, I don't know how long. That ship has sailed because I don't even know if there's a way in which we can reverse that legislation at the moment. So it is proactivity. And that's why I'm saying, even for these acts that we have got in place now, that ship has sailed. Let's not be thinking about NHIF. NHIF is gone. Can we play our role in terms of giving our input? And that's why I say, even for some of the associations who have got a seat on the board and are yet to take them, we're making policy decisions without them. They cannot come and join later and now complain and say, you know what, our participation, you had that opportunity to do it. And that's what I've said. More importantly, let us play our part. Now, why is this current initiative aligned with the current administration? You know, there's the bottom-up economic transformation agenda. And it is an economic transformation agenda. So you must remember, primarily, healthcare is not center stage there. Healthcare comes in only because health is an enabler for economic transformation. You know, without health, all of the rights are indispensable. You can't talk about freedom of expression and freedom to demonstrate and so on if you are unhealthy. So, but more importantly, economic transformation again has got an impact on our health, because economic transformation is going to have an impact on the social determinants of health. You know, there's that saying that poverty is bad for your health, isn't it? There's bidirectional causality between poverty and ill health because of the various, because of the various deprivations that people have when you're poor. It translates into adverse health outcomes. So these are disproportionately concentrated amongst the poor. So those two are aligned in that sense. So what policy proposals came up to sort out the problems we had? First of all, we need to strengthen primary health care. A stitch in time saves 9. And even in healthcare, that holds true. So what we're saying is, instead of spending so much money waiting for people literally to get unwell and then managing them, let's try and look for a way of being able to help those who are healthy stay healthy. That's the essence of primary health care. So, first of all, there's a community health system that was proposed, and that's why we have the Primary Health Care Act, which is a separate act from the social health insurance one. But you've got primary care networks. So we're looking for a way. First of all, I talked about referrals earlier. I said, let's have people start at the base of the healthcare system. Level 1 is community health promoters who are going to be going around households and so on. And I was telling my colleagues, the doctors, the other day, when they were really fighting this issue of community health promoters, you know, you can't be playing in the Premier League and then you start fighting with Shabana FC. Where are we even coming in fighting about what roles doctors play versus community health promoters? What we should be looking for ways is trying to ensure that these community health promoters do the right thing. They're empowered to be able to perform their role, and then they'll be able to channel people to the primary care facilities where they can be able to access care and move up. Because when people are earning 10,000 shillings a month, I told them, would you want to, as a doctor, take that role? I'm sure we can. They will take you, yes, but I don't think you'll be happy with the 10,000 shillings a month. So let them play their role. You can understand the reasoning behind it, because at the end of the day, they're the people who will be able to give basic health advice. If you train them properly, they can take blood pressure, they can do blood sugars, and you tell them this, if it gets to this level, it's one who needs to go to hospital, and so on and so forth. So let them play that role in terms of the healthcare system. Then the key thing is, how do we resource, how do we finance primary healthcare facilities? Because they're going to play a critical role. And even for us as the social health authority, the challenge is, if people go to those facilities and can't get the care, then we have a problem. Because they will say, you know what, you know how Kenyans will say, pesa yetu ilichukuliwa, and you go to hospitals, there's no care, all right? So for us, we have got an interest in ensuring that those primary healthcare facilities deliver the services that they are supposed to deliver. And given that health is a devolved function, that's part of the reason why we have got to engage county governments, we have to engage the private sector, we have to engage the faith-based sector to ensure all facilities are running. And for us, we're not going to discriminate. You can go and get healthcare from any facility, and we'll pay for it. And that's why we're now moving to output financing, where we are paying for a service being delivered. And that's the reason why we need healthcare facilities to be working. So, based on this model, hopefully we can be able to, especially NCDs, in terms of stemming the rising burden, we can be able to detect early. And if you detect early, we can manage better and have better health outcomes. How about insurance penetration? You know, we've got 3 dimensions of universal health coverage. And I'm going to say 3 dimensions, the breadth in terms of how many people are covered, right? Now, what the intention is, through the UHC initiative, we're going to make sure that more people are covered so that we pre-finance healthcare and people don't have to pay for healthcare service at the point of service. So, through UHC, we are saying, first of all, we need to make it mandatory. And this is one of the things that people have got a real issue with. And you know anything when there's change. But you understand the logic is, if it's social health insurance, first of all, we have to have most people have to be covered. Otherwise, the business model does not work. So this is where the section 26.5, which is what is being challenged in court, came about. Because how do we make sure that people pay? I don't think we're going to be arresting people in the street and asking, do you have an ID and do you have the social health insurance card? And if you don't, we take you and lock you up. I don't think that will be a very popular way of doing it. So what they thought about was saying, before you access other government services, use it as a point to be able to ensure people enroll. I know it is something that is controversial and I won't delve into it because it is in court, but I would challenge anybody else to tell us, how else do you think we can enforce this? Because, for example, when we go to the bank and want to open an account, they tell you these are the requirements. Give us your ID. If you don't have one, they send you to NRB to get an ID. If you don't have a PIN, they send you to KRA. I don't know whether that is constitutional or not, but that is for you to decide. But there has to be a way in which we enforce this. Then, paying for indigents and those who are vulnerable. The government has said that anybody who is genuinely unable to pay should have the premiums paid for them. Then the benefits package has been expanded, and that's the intention. And it's been expanded, and that is about the scope of the services that we're going to be offering. So that's the depth dimension of UHC. And then increasing the proportion of benefits covered. Catastrophic health expenditure most of the time comes from chronic illness, critical illness. I've never seen anybody go broke or become indigent because of having malaria, especially if it's a simple case. So the chronic illness and critical illness was a component, and that's why the Emergency Chronic and Critical Illness Fund was introduced. So again, we're increasing the proportion of benefits covered so that if you're under the Social Health Insurance Fund and you exhaust your benefits, then we move you on to the Emergency Chronic and Critical Illness Fund. Now, in terms of operational efficiency at NHIF, the Act says only 5% of whatever revenues are received, I'll use the term revenues, can be used on administrative costs. So there's a cap on that, and that is actually a very tight margin, because I think at the moment we're still at the range of 10-12%. So that means there's going to be a lot of cuts in terms of administrative expenses. Then the Act also mandates us to periodically engage stakeholders in an organized manner. And I'm saying stakeholders meaning the general public, in addition to stakeholders like yourselves. And then there's the aspect of technology to digitize the process, to make our processes more efficient. And then there's talk about reconfiguring healthcare provider compensation mechanisms to be more aligned with the objectives of UHC. I've talked about having one standard scheme and abolishment of the enhanced schemes, and then our fraud detection and fraud prevention systems just have to be stepped up, because one of the ways of deterring fraud or engaging in fraud, you see that it's always an economic motive. And if we can get to a point where people don't get paid for fraudulent behavior, it'll just kill it. In fact, if anything, it'll cause even bigger problems, because somebody will say, somebody else, I did this for you and I didn't get paid. So that's the only way to kill it, because once the money has been received, these efforts at recovery and prosecution, much as in the event the system doesn't detect it, we will do that, but that's not the objective, is to prevent the fraud in the first place. A lot of the functions that we had at NHIF, I've talked about accreditation. This regulatory function has been moved to other regulatory bodies. So for example, KMPDC at the moment is the one that accredits, in terms of accreditation of facilities, is involved in that. Empaneling and contracting will still be a role of the NHIF, managing the funds, but claims management has been put again in a specific office. And there's a lot of controversy, I know, around the issue of outsourcing some of those functions. And I'd like to say the anxiety is understandable, but I don't think it is necessarily warranted at this point. One of the things that was put in place during public participation was the Act had said the Social Health Authority shall outsource certain functions. Later on, it was amended to may. So now it is not obligatory, it is discretionary, right? And it'll be discretionary, and it'll only be done if it is one of those where somebody can do it more efficiently and is going to impact positively on our costs. Now, there are a lot of concerns about the issue of zoning of the different areas, and we were zoning the country with a view to minimizing the risk and enhancing efficiency amongst the different providers. However, the reasoning is this: if we had only, especially we're going to be heavily IT oriented in the new arrangement, and we're only going to have to verify claims for a small percentage as opposed to the large number we're doing currently, then we don't need as many boots on the ground in terms of people who are QAs covering a region. Otherwise, you might have somebody moving from Kisii to see one case to verify that there's one case that was flagged by the system. Then you have to spend the rest of the day traveling to Migori and so on. So why don't we use companies who already have these resources on the ground and use them to verify that for us? That is the reasoning. But that is a decision that we will make as an authority when we get there. So in terms of leadership, the constitution of the board was very well thought out and defined in the Act. And that's why I'd like to say, for the first time, I think, we have got four doctors on the NHIF board. And in addition to that, we've got significant